Good afternoon, and thank you very much, Dr. Kanchi Murli and the scientific team of the 15th National TE sessions for having giving me this opportunity to be speaking on comprehensive TE and update. I bring you compliments from my hospital, Fortis Hospital, Mulund, Mumbai, and I'm just going to talk on intraoperative TE, comprehensive TE exam with some tips for youngsters who just been initiated into TE. I just want to give them an idea about how they could use other radiological means for understanding the anatomy is relevant to TE. Just speak and brief about the other TE guidelines to guide the anesthetist. We need to know what we hope to achieve by TE. As a cardiac anesthetist, my job would be probably to pre-confirm the diagnosis that has already been confirmed by cardiology colleagues, but also determine if there are interim changes, guide the surgical interventions and the management, evaluate the results of the surgery, and help diagnose the etiology of the hemodynamic instability. Also detect unsuspected pathology like a PFO, aortic calcification, a left SVC, and definitely it would be useful in congenital volvulus during CPP weaning, in transplant anesthesia, etc. But understanding the comprehensive use is just the first step in becoming an expert. And if you want to achieve what you set out to do, we need to practice about it. We need to focus on what is abnormal and normal and confirm in other views and modalities. Throughout this session that you're going to be attending, you're going to see the utility of 2D, 3D, color flow, spectral Doppler strain, for seeing that the patient is put up on the right path of diagnosis and recovery. But first, we need to understand that there is no harm that needs to be put on the patient by implementing this extra modality of monitoring. These are the various guidelines. As for the comprehensive T guidelines, they started in 1999 by Dr. Shane Weiss, and then Scott Reeves, and subsequently we used what Dr. Rebecca Han and her team has proposed as a 2028 view comprehensive intraoperative TE examination, which is what we follow today. There are numerous other guidelines about mitral stenosis, aortic stenosis, regurgitations, wall lesions, congenitals. Also, there are guidelines specific for the thoracic aorta, and similar guidelines exist for the European guidelines as well. What I'm going to suggest to our delegates is to log on to the wdirector.com, go to the Eco Library, which is a wonderful academic site with a lot of information about TE. And if you just want to check on comprehensive TE, I would suggest you go to the 2018 12th National TE and check on Dr. Professor Unikrishnan's guideline talk about an Avana talk about comprehensive TE. That would be a good place for you to start. As a scanning position is concerned, there is upper esophagus, mid esophagus, transgastric, and deep transgastric. The upper esophageal views are the upper esophageal pulmonary vein view, the aortic arch long, and the short axis views. Going on to the mid esophageal views of the 4-chamber, 3-chamber, 2-chamber, interspersed with the commissural view and the long axis view. Going on to the aortic wall long axis views, the ascending aorta short and the long axis, and the pulmonary vein view, which I'll come to a little later. And then the aortic wall short axis and RV inflow outflow, the two bicable views. The left atrial appendage has been highlighted in this recommendations as well. It is a very ubiquitous structure which is present in the anterosuperior aspect of the LA, pointing superiorly, but also a very dangerous place because of the clots that can develop, especially patients with atrial fibrillation. You need to be watchful in the intervention that you do for the appendages in the clot and the stroke management. But it can be confusion because of the pectinate muscles or the LA wall itself, appendage wall itself, which can be lying in the pericardial space, giving a false impression of a clot. The recommendation, therefore, are to evaluate the left atrial appendage in multiple views, multiple planes, and also definitely use the X plane to see, because there are a lot of anatomical variations that are there for the left atrial appendage. Going on the transgastric view, the famous three views of the the basal, the mid, and the apex. Going on, turning to the right, it can give the RV basal view as well as the transgastric RV inflow outflow view. Normally, many of us like to go focus on the RV and then increase the angle up to 120 and get this kind of RV inflow outflow view where the aorta B is in the center, the supravena cava, the right atrium, right ventricle, and the RV out for the pulmonary vein and the pulmonary valve and the pulmonary artery is seen very clearly. The modified transgastric view for the RV before that is a follow-up of the deep transgastric 5-chamber view. Again, we just turn to the right and then focus on the RV and see align it in a manner that is along the liver, and this gives us a unique opportunity to do the TAPSE or the annual excursion of the lateral part of the tricuspid, which helps us to get an idea about the right ventricular function. Also, the two chamber, the long axis view, and the RG transgastric RV view will complete the scanning sequence. The small tips that appear right through the guidelines, one of them is to optimize LV length, the intention of making sure that you don't miss out calculating the volume or the size of the LV properly. Also, it has other benefits. For example, in this case, it just highlights that you would missed out this apical VSD in this foreshortened view unless you're if you're not done the elongation of the LV by doing the blood deflection of the mediasophageal positioned probe. Also, it's a good idea for the cardiac anesthetists to look out for trouble in the lung. Any presence of pleural effusion, as in this case, was picked up by just turning the probe from the four-chamber view onto the left, picking up this pleural effusion, and subsequently, when it has been drained and the lung expands, you can see the image has changed. Dr. Cavayas and his colleagues have suggested multiple sequencing protocol from the coronal and sagittal view of the lung and call it the transesophageal lung ultrasound examination to pick up things like hepatization, fluid as you already seen, and even the effects of recruitment of the lung where the image changes as you can see once the PEEP has been applied. Now I would just give a couple of examples for our students to see how CT scan or MRI can help you understand the TE anatomy better. For example, in this, you could probably you can see the ascending aorta, the SVC, the main pulmonary trunk, and the right pulmonary artery going out here. I just flipped the image to give you this idea, and this is exactly what has been recreated as you just withdraw the probe and see the ascending aorta, the SVC, and the pulmonary artery behind. And this is as you turn the probe more to the right, you will be able to see that the pulmonary artery and the SVC are in close relationship. And here you can see the pulmonary artery catheter in the SVC and subsequently in the right pulmonary artery as well. Similarly, the pulmonary wall and artery, the CT scans will tell you that the pulmonary artery is the pulmonary artery or the pulmonary wall rather is positioned at right angles to the aortic valve. And if you would want to develop that image from say aortic valve cross a short axis view, just by turning won't be enough. You need to withdraw the probe so you come to the level of the coronary arteries, and probably you'll be able to see the pulmonary artery in the right and the left pulmonary artery branches. This is what esophagus sees as it sees visualized on the top. In a traditional bicaval view, you would see the SVC, the RA, the LA, and the IVC as one plane. Now, from developing but for developing an image where the right pulmonary vein or upper pulmonary vein is seen, you need to withdraw the probe to see a good length of the SVC. So the LA, the RA, and the SVC are seen. Further turning with the image sector, with the color sector there, we'll be able to demonstrate the right upper pulmonary vein is entering the LA, and this is another image which shows the left upper pulmonary vein entering the left atrium. Dr. Patil and colleagues have highlighted how to image the thoracic aorta. One of the things they suggested for imaging the blind spot the aorta, which probably it's segment 345 for the ascending aorta, would be by doing what is known as an A view, where a fluid-filled catheter is positioned in the distal trachea and the left bronchus, and on inflating you would be able to see something like the aortic cannula, or even in this case the brachiocephalic trunk, and you can see it disappears once the balloon is deflated, and as it is the fluid is again pumped into the balloon, it becomes visible again. In this case study is highlighted a very dangerous high level plaque which would increase the risk of thromboembolism, embolic events rather, for this patient. Since we're looking at the SVC, we'll also look at this study which tells us that the respiratory variation in the SVC are very important to predict fluid for predicting the fluid responsiveness, and thereby one of the scans that have to include is measurement of the variations of the SVC. Dr. Ender has published quite a bit extensively on the circumflex artery, and he's given two protocols from the aortic wall short and the long axis to trace the SVC and its intimate relationship with the coronary sinus. Similarly, Dr. Madhav Swaminathan, Dr. Feroz Mahmood, and Alina Nikora have also talked about this. The same authors also came together to publish this wonderful surgery-based approach from the AC as well as and along with the Society of Thoracic Surgeons to see what exactly the cardiac anesthetist needs to be aware of while dealing with valvular lesions or CABGs or even mechanical circulatory devices. It is one publication that I think is very important, one of the most important publications from this recent times, and I would request all of you to kindly go through this. As far as the 3D is concerned, Dr. Poonam Malhotra colleagues, along with Dr. Naman, Dr. Kanchi, and uh, Dr. Yatin Mehta, we said have given this guidelines in 2016 about 2D versus 3D views, and it's an excellent article. In the same year, Dr. Annette Vegas, in the same article, in the same issue, has spoken about, Dr. Vegas has spoken about 3D dimensional echocartography. It's a very nicely written article, and so people getting into 3D, I would recommend you to go through this. One of the first things to realize as you go into 3D is the use of the X-plane. And here I can just try and show you, this is the traditional mid-path level short axis view, and just as a cursor alongside in the primary image, just by moving the cursor to various directions, you will be able to see different aspects of the left ventricle. Like in this case, you just look into the left side by point, you see the cursor here, the pointer here, and if it goes to the right side, you can see now the cursor is actually transecting this part. It is looking to the right side, and you can see the anatomy, the inflow pattern of the right ventricle. All this has been achieved just by changing the cursor which runs across this sector in the primary image. Similarly, the 3D is 3D gives you excellent, and I think as cardiac anesthetists, we would be probably be very much interested in developing the surgical view or the enhanced view of the mitral wall, seeing the full volume loops, the gated full volume projections for detecting the lesions in the IAS, and the position of the various relationship of the various positions of the walls. The guidelines for performing a comprehensive transit echocardiography in children and all patients with congenital heart disease. This has been recommended. This is the guidelines that is available by Wishlaski, and it gives excellent detailed guidelines for evaluating in various congenital cardiac conditions. Also gives excellent recommendations for usage of the 3D. Most of the recommendations are for procedures, devices, baffles, and leak management. One of the quirks of pediatric TE is that the echocardiographers frequently like to flip the image to make it equivalent to what they see in a transthoracic, and it gets some getting used to. T in TAVI is another indication which is coming up, and here there are multiple things that the echographer can offer the interventionist by telling about the predicting the paravalvular regurgitation, sizing the annulus properly, and also looking at the complication that would likely to occur after a high risk TE. These are perioperative right heart assessment is also a very upcoming issue. 3D TE for RV is now in vogue, and various protocols are developed for assessing the RA, RV, and the tricuspid wall. 3D is having a big role to play. These are recommendations of heart and lung transplantation. This is a recommendation for focused management of orthotopic liver transplantation, and also guidelines are existing for non-cardiac surgery. So incidentally, whenever we work, we come across some views, and this is one of the views that I developed a few years back, thinking that we hit upon something new with the SVC in the transgastric. This is the transgastric bicable view with the SVC, IVC, and the right atrium seen very well. But when we obviously research, we realize that this is a view which has been developed multiple times by various authors, including one from my parent institute. So thank you very much for your patient hearing. I'd like to give special thanks to Dr. Amish and Dr. Satish for assistance in preparing this preparation. Thank you so much. Enjoy the rest of the session.